Yes, that's great. Thank you. Can you hear me all right?
I can hear you.
Lovely. Okay, well, thank you, first of all, Eva, for organising this, and to Diane for being the leading light in AMR and really keeping this conference going year on year on year, which I think is absolutely fantastic. So welcome. I'm Abid Hussain. I'm a microbiologist. I work at the University Hospitals of Birmingham NHS Foundation Trust together with Shazad. And my role there is really infection control doctor and associate medical director. For the next 35 minutes, I guess now, Shazad and I are going to take you through really some very general data and then some specific experiences of AMR and how we work together as a team. I'll do the first half and then Shazad will follow things up with the second half. Could I have the first slide, please? Okay, good. That's us. Thank you. Right. So this next series, this first series of slides really is talking about how the population is changing. And can you just click through all of this, please, so we can see the entire slide? That's great. Thank you. So this is an old data set now from 2017, looking at the change in the UK population. And as we know, everyone in the UK is progressively getting older and living longer. And what's interesting is the new bulge, the new bulge that we're going to see in the 70 plus age group, which is going to cause an increasing amount of pressure, not just on the NHS as a whole, but also in terms of antimicrobial prescribing. Can I have the next slide, please? So this slide really is summarising the change in the UK population on the left. And you can see again, you've got that characteristic increase in the population from 70 onwards. And on the right is the world population. And you can see that by the time we reach 2100, long after I'm gone, we will really be having enormous numbers of people living on the planet. And that's going to have implications not just in terms of natural resources, but also in terms of infections and in terms of antimicrobial management. Next slide, please. So this next series of figures is really going to summarize for you the common causes of mortality in the world based upon 2017 data. And I want to draw your attention to the cause of infection. So here we've got children between 5 and 14, and we can see malaria, HIV, diarrheal diseases, and lower respiratory tract infections being a more and more prominent cause of death in the younger age group. Can we just click on to the next picture? Here we're now looking at the 15 to 49 age group. Again, the similar theme coming out there with infections coming near the top of the mortality risk. Next picture, please. 50 to 69, and here we can see clearly whilst cardiovascular diseases and cancers are right up there, respiratory diseases and infections are catching up. Next picture, please. And then for the older 70 group, again, you can see respiratory diseases coming in at number 3. So, these are increasingly common infections that are affecting all of our age groups, mostly the elderly, and importantly, have an associated demonstrable mortality that goes with it. Next slide, please. This slide is taken from a government document from a few years ago. This is the risk matrix that the government developed in terms of where the priority should lie for the future governments going forward. And you can see what's interesting here in the right bang in the centre is emerging infectious diseases. Now, this was clearly written before we had a COVID SARS-CoV-2 worldwide pandemic, but even at that stage, antibiotic resistance and infections as a group were recognised as a priority for the UK government. Next slide, please. So this is really about how healthcare associated infections, and when we think about how we measure infections in the UK, we are expected as part of a large secondary trust organisation to record the numbers of infections we see in terms of bloodstream infections for MRSA, MSSA, which is the normal version of MRSA, and gram-negative bacteremias. C. diff is still up there, and even though we are in the middle of a pandemic, we are seeing numbers of patients with C. diff. Thankfully, touch wood, no mortality, but certainly disease we have seen. And as part of the other data we have to collect for central government is prescribing of antimicrobials, and I'll talk about that data a little bit later on. All of that data is then fed into the Public Health England servers, and we can access that data either through what's called the second generation surveillance system or by PHE fingertips. Now, PHE fingertips was originally set up by Susan Hopkins and her team, and the beauty of it is it is completely open access and it's free for anyone to use, and you can very quickly look at your CCG or your hospital and you can see how your trust is performing against the national average. And within the fingertips data, there's an AMR section where you can look at bloodstream infections and, as an example, C. diff infections as well. Next slide, please. So these diagrams are taken from a paper that was from a study that was done in the latter part of 2018. And this is really summarizing for you the changes and the trends of the other infections. So you can see a plateauing in the amount of C. diff disease, both hospital and community cases over the last 5 years or so. Next slide, please. Here we're looking at MRSA bacteremias. Again, since 2010, there's been a leveling off. Next picture, please. And here we've got E. coli bacteremias. Now, what's interesting here is that whilst everything else has been flattening off, E. coli's have been increasing. Now, if you look at this diagram, you would be led to believe, I think, that the hospital onset cases are fairly static with a rise in community cases. And I think whilst that data was true for the 18-19 financial year, for the 19-20 financial year, we have seen an increase in the E. coli bacteremias as well. Now, whether that's due to an issue with COVID or not, we can ponder upon that later. But clearly, we are going to start seeing more of an incidence with gram-negative infections. And as we know, gram-negatives are particularly difficult to manage when they become resistant in terms of antibiotics. Next slide, please. This is taken from the report that Diane was heavily involved in, the ASPA report, which came out very recently indeed. On the left-hand side here, we can see the incidence of bloodstream infections across the UK since 2015. And as you can see there, there's been a demonstrable increase in the total number of infections over the last few years. And we can see below that an increase of 32.5% in resistant infections. And that's really where the struggle is going to lie in the next few years in terms of managing those resistant infections carefully and safely. On the right-hand side, we've got the burden of antibiotic resistance. And again, you can see between 2015 and 2019, there has been an increase, although a modest one of 2.4%. But as you can see there in the text, this does mean that 21 out of every 100 people with a key pathogen bloodstream infection had a resistant one in 2019. So that really, again, highlights the incidence, increasing incidence of resistant infections. Okay, next slide, please. Thank you. And one thing that I took this slide from an ESCMID conference I went to years ago, where there was a debate about how we manage physicians' and prescribers' anxieties when it comes to managing infections. And it can be one of these possible combinations. It can be that the antibiotic we give isn't appropriate for the bacteria we're treating. It could be that there isn't appropriate coverage or appropriate susceptibilities of that bacteria for that drug. It could be that the infection is now complicated and widespread. It could be there's an alternative diagnosis, or it could be that clinicians, and some clinicians, particularly those that work in intensive care, can get quite impatient when patients aren't getting better after a couple of days of antibiotics. So all of these things come into the mix when we're dealing with a patient whose infection is non-resolving. Next slide, please. So for those of you who are my age, you'll probably recognize at least some of these things. So the gentleman on the top left is, of course, the first actor who played Dr. Leonard Bones McCoy, and his younger counterpart at the bottom. On the right side is a medical tricorder. Now, you might think to yourself, why am I showing you these bizarre pictures? Purely to indicate that when we are thinking about using antimicrobials in modern medicine, you've got to really look at the patient holistically and look at all the different parts of that patient that make up that diagnosis. Next slide, please. This excerpt is taken from a very old, relatively old paper now, published in 2012, where a Brazilian group coined a new syndrome amongst medical professionals called McCoy's syndrome, where there was a heavy reliance on diagnostics and other wizardry in order to assess infections. And as I keep telling my medical students here in Birmingham, it comes back to the basics: history and examination. These are the most important things that will help us decide A, if there is an infection, or B, how that infection is progressing. You know, you can support your diagnoses with blood tests and other things, but often going back to the patient is a critical part of the work that we do. Next slide, please. This diagram is really summarizing the vicious cycle that often occurs when patients develop sepsis and they develop resistance. So if we start at the top, a patient with sepsis receives broad spectrum antibiotics. through issues with inadequate dosing or prolonged durations or ineffective de-escalation, there'll be ineffective stewardship. That then leads to resistance, either in the short term or the long term, resulting in older antibiotics. And some of our old antibiotics are good, but they are very toxic, particularly nephrotoxic. And that then leads to poor outcomes, which then starts the cycle again of ongoing sepsis. And so the only way to break this cycle is, as Public Health England says, start smart, then focus, and appropriate IV to oral switch after 48 hours after clinical assessment. Next slide, please. So this is the previous. This is a reference to the previous ASPAR report, and to be fair, I should have updated the slides. But really, what this is showing you is a series of pictures which demonstrate where information is available for the general public and for professionals about AMR going forward. So when Dame Sally Davis was the CMO, she had a report. Diane and the PHE SPAR group produce an SPAR report every year. WHO had a global action plan. And of course, the news outlets are another way to hear about AMR, as are fiction with a BBC Radio 4 play. And at the bottom right is a, well, I would call it a comic, but I suppose they're called graphic novels, set in the future, where a surgeon is managing her practice in London, where there is almost complete antibiotic resistance. And it's just an interesting take on trying to get that message out to a different group, a different audience. Thank you. Next slide, please. So AMR very much is a threat to public health and patient safety, and we do know that resistant infections do have an increased incidence of morbidity and, importantly, mortality, and that morbidity can result in some lifelong complications and lifelong disabilities. We know that extended stays in hospitals are a problem, and we want to try and minimise patients staying in hospital as much as we can. We know that healthcare costs are increasing. So as an example, when I first started doing these talks some 10 years ago, the average cost of an NHS bed was about £400. It's now in excess of £1,000. So these are expensive complications we have from resistance. In terms of treatment options, yes, they are reduced, and there sort of 10, 12 years ago, there was some concern about there being a lack of future in terms of development of antibiotics in terms of the pipeline. But now, thankfully, we are seeing a few more drugs coming online. But even then, they do need to be used responsibly as part of a larger stewardship program. And sadly, we do occasionally see the untreatable infections, or those that are very difficult to treat. They require combinations of quite old-fashioned and quite toxic agents, usually with significant renal complications. Okay, thank you. Next slide, please. This is taken from the O'Neill report, published a little while ago now, but really does try and put the concept of AMR and its deaths into context. And I think, you know, as time goes on, we certainly will be seeing more and more AMR, even in developed countries, let alone the low middle income countries. It's also worth pointing out that whilst we worry very much about the development of AMR in terms of diseases, sort of cross transmission of infections, the antibiotic pressure is also significant. So if you go onto the PHE fingertips site, you can look at the consumption of antibiotics over the first pandemic of COVID, and you can see a huge increase. We've had it in Birmingham. It's a national trend of antibiotics as a result of the pandemic. Next slide, please. And this is another slide again from Lord O'Neill's report, just summarising where the main pressure points are. Asia and Africa and Europe are sort of significant areas, but I suspect those will only increase as time goes on. Next slide, please. So this is taken from the government website, quite a long time ago now, where Jeremy Hunt, who was the Secretary of State for Health at the time, was talking about managing E. coli infections. And I think when we sort of think about infection control as a whole, I refer to it as being a 4-pillar strategy. So screening, cleaning, hand hygiene and AMR are all part of infection control. And the pharmacists and the independent prescribers can do a lot to support infection control through careful and diligent prescribing. Next slide, please. And this is just talking about Jeremy Hunt was talking about how E. coli infection should be preventable and how all staff should wash their hands. And most of the things we have sort of managed to tackle over the last 5 years. I think that the problem really is going to be saying that E. coli is preventable is a little bit difficult because there's so much community onset infection. Okay, thank you. Next slide, please. Right, so just to summarize very briefly the antibiotic development pipeline, we can see that we've had huge development and huge strides in all of our classes of antibiotics, but I think now for the next sort of few years, the focus is going to be not just on developing novel fluoroquinolones, but also beta-lactamase inhibitors. And I think the pairing together of novel combinations like meropenem valbibactam or ceftolozane tazobactam or ceftazidime avibactam, these sorts of combinations broaden the spectrum of drugs we're familiar with, but allow us to tackle some of the more resistant gram-negatives. Okay, next slide, please. Thank you. So what is AMS? And so this is the NICE definition published in 2015. And it's a very good definition because it does talk about the approach to AMS either being at the organisation level or at the healthcare system-wide level. And here in Birmingham, we have very much got a system-wide approach in terms of AMS, where we partner as a secondary care organisation with the Birmingham and Solihull CCG to not only help and support our GPs, but also to allow communication of data between the two sovereign organisations. Okay, next slide, please. And then these are just some stakeholders we like in that process. So Her Majesty's Government, PHE, BSAC and NICE. Thank you. Next slide. So this was really my final slide before I hand over to Shazad, which is I often get asked, when it comes to stewardship, whose responsibility is it? And the answer is it's everyone's. And I often say to our nursing staff in particular that when you're on your drug round and you're giving out your antibiotics, you are the last line of defense between the patient and the drug. And it's really the nurse's duty, I think, to check and challenge why those prescriptions are being given, whether it's the junior doctor or the pharmacist or the consultant. I think we all need to be challenged on these issues. Thank you very much. I'll now hand over to Shazad. Shazad, please.
Thank you very much, David, for that introduction, and Aoife for the opportunity to talk to a wider variety of healthcare kind of students. So thank you. So first of all, to talk about the kind of antimicrobial stewardship team, as Dr. Abid Hussain has alluded to, antimicrobial stewardship is an interprofessional effort across all sectors of healthcare in order to deliver optimal treatment. We need to obviously minimise the risks of antibiotic resistance as well as side effects from antimicrobials, and that is best achieved through a combination of different healthcare professionals working together. Here in our organisation at University Hospitals Birmingham, we have a core team and a wider team. The core team consists of the antimicrobial pharmacist, the infection control nursing staff, and microbiology and infectious disease specialists. But there is a much wider team who also play a very important and crucial role in ensuring and assisting the delivery of AMS. That consists of the ward pharmacists, healthcare assistants, as well as Dr. Abid Hussain has mentioned, GPs and in primary care. We have colleagues who also kind of share our kind of desire and enthusiasm to make sure that we preserve the antimicrobials that we have and ensure their appropriate use. We have, in Birmingham an antibiotic advisory group that dentists as well as GP practice, and we're trying to encourage veterinary colleagues as well to also join in that effort to try and push forward antimicrobial stewardship and reduce resistance. So next slide, please, Aoife. So in terms of providing quality assurance and delivery of antimicrobial usage, one of the key recommendations from the NICE guideline that Dr. Abid Hussain mentioned in 2015 was for organisations to develop their own antimicrobial guidelines to support stewardship. These guidelines usually take account of the resistance patterns, as well as prescribing information from locally gathered data. And experts in different specialities all contribute towards the development of these guidelines, and these are peer reviewed by an antimicrobial committee who assess the guidelines and make sure that they're appropriate for use. you will find most hospitals have their guidelines published in a smartphone app. We have our own on MicroGuide, which was recently updated and launched earlier this week. It's free to access. And the good thing about MicroGuide is that you can look at all hospitals in terms of their antimicrobial stewardship guidance and recommendations, and see, what different hospitals are doing. So well worth having a look at in terms of it's free to access, and having a check on seeing what our colleagues in local hospitals and up and down the country are doing. So having antimicrobial guidelines does provide the assurance that we need and provide the kind of guidance to our prescribers who are making the decisions to start treatment, as well as nursing staff and pharmacists who are supporting those prescribing decisions as well. Next slide, please. So why do we need antimicrobial guidelines? I guess is a good question, and we need antimicrobial guidelines to deliver stewardship. Antimicrobial guidelines are evidence-based and provide the principles and the recommendations for what we should be doing in terms of different infections and treating them with antibiotics. As we know, antibiotics in their mode of action will kill bacteria, and one of the unintended consequences are ecological adverse effects. This being, for example, in the case of the human gut, leading to the biodiversity of both good and what you might call bad bacteria, leading to the consequences of Clostridium difficile, which you may have heard of, is a infection that can lead to a chronic illness, sometimes multiple recurrences. So we do want to avoid some of these unintended consequences of inappropriate antimicrobial use by having good guidelines that suggest what antibiotics should be given in certain indications. Diagnostics are an expensive resource. We've seen during the COVID pandemic how the lack of diagnostics and can lead to further problems, especially when we consider outbreaks. Having real-time and rapid diagnostics can lead to timely kind of interventions and treatment being given to patients. So having good use of antimicrobials and appropriate use of diagnostics will also ensure their continued use. Avoiding misuse and inappropriate use of antibiotics will hopefully lead to a reduction in resistance, and appropriate de-escalation of treatments can also lead to a prompt discharge and effective care of that particular patient. So it's a combined approach from prescribers, pharmacists and nursing staff that will deliver that. And one of the kind of scenarios where this applies is, for example, in IV intravenous antibiotic to oral switching of antibiotics. This can lead to a reduced burden on inpatient beds, as Dr. Abid Hussain mentioned. The cost of this has increased in recent years, and these are vitally important in terms of ensuring patient health. There are a number of ways in which we can measure the effectiveness of antimicrobial guidelines, and we can look at improvements in infection cure rates, a reduction in surgical infection rates, and then hospital admissions due to recurrence of an infection. But not always is it easy to kind of understand the benefits of AMS, but there are a number of different measures which we can look at from a hospital or a ward or an organisational point of view, or wider nationally or at a regional level as well. There are various different measurements that we can look at to help us understand whether we're making a difference, a positive difference in terms of resistance. Sorry, next slide, please. So applying policy to practice isn't straightforward. Over the last 50 years, 80 years, as Dr. Abid Hussain mentioned, we've seen a golden age of antibiotic discovery. We've seen lots of new antibiotics come onto the market and allowed us to treat lots of various different types of infections. However, due to the overuse and misuse of these antibiotics, we're seeing challenges in terms of healthcare associated infections. So therefore, we need to optimise the use of existing antimicrobials, and that is a challenge given the ageing population and increasing obesity. And obviously, drug trials, as we heard earlier on this morning, are difficult, and especially in those patient groups, trying to get the numbers and trying to get the information and getting a drug onto market in those kind of ageing or obese populations hasn't always been done. So knowing what dose, what duration, what treatment is most effective is a challenge. So while it might be straightforward to give a guideline or a recommendation as to what we should be doing, actually implementing it does present some problems. So we do need to optimize our antibiotics, and we do need to make sure they're delivered safely. And preventing hospital transmission is one of the ways in which we can reduce antibiotic use. Preventing transmission from one patient to another will halve the number of antibiotics being used on that particular ward. So working together between nursing staff, infection control staff, as well as pharmacists and doctors, we can try and collectively work together to minimize transmission and optimize and reduce antibiotic use. Next slide, please. So how do we deliver, and what organisations do we have to support effective antimicrobial use? Obviously, Antibiotic Guardian campaign was launched now in 2014 to kickstart collective effort from health and social care professionals, students, human and animal health, as well as members of the public, to work together to slow the spread of antibiotic resistance. And certainly some of the material that has been shared recently over the last week will hopefully have made an impact in all kind of areas, both in healthcare as well as outside of healthcare. The other organisations that I would just want to briefly mention are the Infectious Disease Society of America. Is a community of thousands of different individuals, of physicians, scientists, public health experts, who all specialise in infectious diseases and have an active role in terms of developing guidelines and expert clinical practice. So another resource that hopefully after today, and you're all enthused about antimicrobial resistance and stewardship, we'll have a look at. Hopefully you've all have heard of NICE, which provides guidance at a national level here in the UK to improve health and social care. Its evidence-based guidelines provide support to us in the hospital as well as in the community in terms of what treatments we should be using. And also, as you know, they also produce technology appraisals which guide us on the best use of new and existing treatments. Lastly, I just want to mention the British Society of Antimicrobial Chemotherapy, which is a UK-based multi-professional organisation with worldwide membership for clinicians and scientists in all fields who have an interest and a passion in antimicrobial management. It is now free to join, so I'd encourage you all to sign up and help influence our policymakers and provide, as well as that, the BSAC also offers opportunity to be involved in working parties and journals and access to lots of resources which are educational and provided online as well. So well worth having a look at as well. So all these organisations and institutions help us deliver optimal antimicrobial therapy and reduce resistance as well, and working collaboratively across organisations as well is a fantastic thing, and hopefully has brought many benefits in the recent years and will continue to do so in the years to come and in the future. Next slide, please. So in the UK, as Dr. Abid Hussain mentioned, the 5-year AMR action plan set a national challenge to reduce the total number of resistant infections. I think it's unique. I don't think there are many countries in the world that have such ambitious targets and set a kind of a specific target. And for example, one of the targets is to halve the number of healthcare-associated gram-negative infections. So to do this, we do need to develop real-time patient-level data that looks at the pathogen, the place and where infections are occurring, develop treatment and plans that are taking account of resistance histories in order to optimize the life-saving treatments which we have in terms of antibiotics for serious infections. This includes obviously managing patients who develop sepsis. And this leads on to the next slide, please, where we have a difficult balance between ensuring prompt antimicrobial use to manage patients with severe illness against the kind of consequences of inappropriate use, which we've talked about just now in the last kind of 20 minutes, but also throughout today as well, is about, how do we manage this delicate balance between, meeting expectations of the public and healthcare professionals versus the health, the consequences of inappropriate use. Next slide, please. So we have a number of milestones to achieve in terms of, as I mentioned earlier, measurements aren't easy in terms of how do we quantify what success looks like, but at a prescriber level, we do look to audit and feedback information to prescribers at a GP practice level, at a board level, at a hospital organisation level, in terms of how we're doing in terms of compliance to local and national guidance. Are we abiding by the principles of good AMS? And this includes, are we following our guidelines? Are we adhering to, prompt IV to oral solution? Can start taking oral medication? Are we switching the intravenous antibiotic to an oral antibiotic? Are we de-escalating our antibiotics in light of kind of culture results and investigations? So we have a program of audit and feedback and monitoring, which is ongoing. And so we can kind of tackle areas of poor practice where it arises, and that learning is shared accordingly. Next slide, please. So as I mentioned, we do this through feedback, linking into kind of, because some people don't take account of, just the resistance and the consequences of that. Some people kind of respond more to the kind of the hard cost of a multi-resistant infection. We do need to define the roles of different members of staff, in particular prescribers and nurses. Knowing you as a prescriber, as a clinician, taking responsibility for the prescribing of that antibiotic. What kind of level of responsibility does that entail? And as a nurse, giving the patient that medication, you shouldn't be, as a nurse giving that medicine, you shouldn't just be thinking about administering it and following the doctor's instruction. You also have a responsibility to challenge, to question, to make sure that you are giving, the antibiotic where it's needed and the right dose at the right time, etc. Next slide, please. So key stakeholders are all staff, but in particular prescribers, nursing staff. We get success through engagement of all these different professionals. So in our Antimicrobial Stewardship Committee, we do encourage our good representation from across a variety of specialities, across a variety of different healthcare professional groups, to make sure that those champions of AMS carry that forward in their own professional groups and their wider teams in their local areas. We do rely upon them in order to kind of share the message of what we are trying to deliver in terms of any new guidelines that we develop, but also to feed back to us any challenges that they have, any difficulties they experience in terms of treatments that are given, so that we have this two-way communication and feedback to ensure the optimal use of antimicrobials. The next slide, please. I think this is just highlighting what I've already mentioned. It is there's a key triumvirate in terms of delivering stewardship to avoid resistance, but there is a wider team beyond the pharmacist, the nurse, and the doctor who also play a role in antimicrobial stewardship and reducing resistance. Next slide, please. So to talk about some of those, the three key stakeholders in a bit more detail, we have the infection doctor, who can either be an infectious diseases specialist or a medical microbiologist, who take the role in terms of supporting and reviewing the patient's antibiotics. We often do ward rounds with an infection control nurse as well as an infection specialist doctor to review the management of patients. We also visit patients at the bedside whenever there's a patient who develops a bloodstream infection. This requires a kind of a detailed review of the patient, why they developed that particular bloodstream infection, what the most appropriate antibiotic would be for that particular patient. And this has shown that in doing that kind of detailed review at the bedside, looking at the pathology results, working with the lab scientists in terms of what, cultures are isolated and at an early stage as well, using the appropriate diagnostics, we can ensure that patients receive the right antibiotic and not receive an inappropriate antibiotic. That may lead to both resistance, or it may lead to kind of poor outcome. So we do need to kind of harness the strengths in terms of the infection specialist doctor working in conjunction with the laboratory scientists in delivering the right sort of treatment advice. The next slide, please. As an antimicrobial pharmacist, I work with colleagues across the various teams. We all work together in terms of looking at the patient and making sure the most appropriate treatment antibiotic choice is given. We help organise our kind of microbiology ward rounds and develop guidelines in conjunction with our colleagues in different specialities. We liaise with our kind of local and national groups, antimicrobial pharmacist group that I am part of and chair, and kind of there's a willing enthusiasm amongst all of my colleagues in the region to develop kind of tools and resources and share good practice and learn from each other, because ultimately we're all working towards the same goal. And harnessing any good practice from another organisation is something that we all kind of look to to emulate and try and share good practice. Is avoids us all having to reinvent the wheel. Education training across all specialities is key, and we all do some teaching to all different professionals and raise the awareness, as we're doing today, to yourselves as students. And it's an ongoing aspect of our roles. And ensuring an appropriate new antimicrobials added to the formulary is something that we all also kind of have a role in terms of antimicrobial pharmacists, is to establish a process for horizon scanning, looking at whether the treatment's going to be effective, looking at the costs, looking at the kind of what dose and what information do we need to give to our colleagues who are going to be prescribing this particular new antibiotic, and ensuring that education is delivered and it's centered on trust formulate in a responsible manner is something that we all kind of take a huge amount of care and responsibility in. Next slide, please. The nursing influence is something that we are trying to kind of encourage. Unfortunately, it is something that is underplayed and isn't fully kind of harnessed. A lot of organisations are moving towards improving the nursing kind of knowledge and awareness so that they can challenge and make sure that patients are, reviewed according to how they are at any moment in time in terms of their treatment of antibiotics. We did a survey recently in the last couple of months, which highlighted a gap in some areas and lack of confidence in certain particular aspects, which we're trying to target through developing resources and raising their awareness of nursing staff, so that they can, not just do the basics in terms of checking the patients are not receiving an antibiotic when they are allergic to it, but also in ensuring that samples are taken in a kind of appropriate manner before starting antibiotic treatment, ensuring that culture results are reviewed in a timely manner, promoting self-care, and ensuring that patients, when they are discharged from hospital, take the right antibiotic at the right dose and right time. Next slide, please. So one of the tools that we use in our organisation and is used widely up and down the country has been a real success, has been the Start Smart Then Focus. Released in 2011, this toolkit formed the bedrock of advice that we've been issuing and putting in place in all of our guidelines. Next slide, please. So Start Smart, what does this mean? So this means documenting the clinical indication, why you've started the antibiotic. What's the rationale? What's the investigations that support the initial investigations or kind of assessment of the patient that has led to the diagnosis of an infection, and prescribing that antibiotic appropriately, as well as putting a review or a stop date. Next slide, please. After 48 hours, the team, especially the prescriber, should be looking at reviewing that clinical diagnosis and assessing whether the patient needs ongoing antimicrobial therapy. If the patient requires ongoing antimicrobial therapy, there are a set of actions to take. However, this is something that is a team effort. It's not just the prescriber. The pharmacist, the nurse, anyone looking after that patient has a role to play in reviewing that patient and ensuring the sort of the then focus aspect is carried through. Next slide, please. So there are 5 antimicrobial decision options that the toolkit advises. Either stopping the antibiotic if there is no evidence of infection. This, at the time when this toolkit was launched, I recall a number of clinicians and pharmacists and nursing staff saying, isn't it doesn't the patient have to complete the course of treatment? There's no such thing as completing the course of treatment if the patient doesn't have no evidence of an infection. So it is absolutely appropriate and safe to stop an antibiotic if there actually is no evidence of infection. Do we need to consider changing the antibiotic, either escalating it to a different antibiotic, or do we need to change to a more narrow spectrum antibiotic? Can we switch from IV to oral? So this is an important decision to make, and that may facilitate an earlier discharge and may allow the patient to not have the risk or the inconvenience of having an IV cannula. If we need to continue the antibiotic, then we need to document the reason why. And the last thing, which has kind of played an increasing role over recent years, is discharging the patient from hospital to receive the antibiotic therapy at home if they need IV antibiotics. This is called OPAT, or abbreviated to as OPAT, so outpatient personal antimicrobial therapy. It's something which a lot of organisations now offer. It releases the inpatient bed so that a patient who genuinely needs a hospital bed can have that space, and the patient who actually just needs IV antibiotics and there's no other reason for them to be in hospital can be discharged safely, minimising the risk of hospital-acquired infections, of course, but also for themselves receiving the right antibiotic, in terms of optimising their treatment and ensuring that that infection is resolved in a timely fashion. The OPAT teams usually consist of a nurse, pharmacist, and doctor, and infection nurses who specialise in kind of giving antibiotics at home. And these patients are reviewed on an ongoing basis, and the same continues to go through as they would have done in a hospital in terms of ongoing review of that particular patient. Next slide, please. Sorry, I'm going over quickly kind of time, so I'll try and not spend too much time in the next couple of slides. So the R4 is something that we've developed locally as a spin-off of what is kind of world-known renown in terms of what, for example, clinical CDC, which is a public health organization in America, put in plain terms, it's ultimately geared towards giving the right antibiotic at the right dose, at the right time, with the right route and the right duration. And the aim is causing least amount of harm to the patient you're treating, and also for future patients. So locally, we developed this kind of R4, which is a kind of mirrors some of the advice and guidance from the Start Smart Then Focus, as well as the CDC. Next slide, please. So to end with, so the key to success, just to summarize, is to develop treatment guidelines that are safe, effective, evidence-based. We should be looking to use narrow spectrum antibiotics as promptly as possible, and stopping antibiotics where they're not needed. We need to raise the education awareness of all staff, particularly ward pharmacists, junior doctors, and nursing staff. We do need to improve documentation and making sure that the clear rationale is documented in terms of why the patient's been starting antibiotics, and delivering timely feedback to all staff in terms of how we're performing, what changes need to be made will help to ensure that the ongoing kind of improvements are delivered. That's the end of the presentation. Thank you for listening. Sorry for going over the time, but do take the opportunity to please use social media, hashtags that Diane has mentioned at the start of the day. And just to kind of say the message again, it is a multi-sector multi-professional approach to reducing AMR. And thank you all for listening. Thank you very much.
Thank you both very much. So if anyone's got any questions for Shazad or Abid, please do raise your hand. We can probably take 2 more questions and then we'll go to...
That's okay. So got Bonnie Vincent.
Hello, thank you so much for both of your presentations. They were really interesting. Shazad, I was particularly intrigued when you were discussing documentation justification of which antibiotics you use and when they're like continued or stopped or changed. That has to be noted down. I was just wondering if there is any associated legislation about documentation, and particularly with like antibiotics that target potential antimicrobial resistant species, or do you think that that could be something which might be incorporated in the future?
That's a good question. It is one thing that different organisations have taken a different tack on. I think there are some trusts where prescribing restricted antibiotics requires a justification and a reason or a code to be given by microbiology before it can be prescribed. It has worked quite well in those organisations in terms of making sure those antibiotics are used appropriately. We've not taken that line in terms of doing that, but with the increasing use of electronic prescribing and electronic decision support tools, we, as the AMS team, regularly review these particular prescriptions and making sure that they're being used appropriately and that durations are reviewed and so on. So it is one that I think is tackled differently in different organisations, if I'm honest. But we do all have a kind of responsibility to make sure that they, these antibiotics, especially those that are broad spectrum or newly introduced, are used appropriately. I don't know if Abid, if there's anything else to add to that.
No, the only thing to add is that sometimes it's legislated locally as part of our targets we have to deliver for the CCG, but there isn't a national framework as
there is. Start Smart Then Focus specifies it, that there should be indication documented. But I hear what you're saying, that it's not legislated. So it's not a but if an organization is not if an organization is not implementing it and CQC turns up and they have lots of resistant infections and lots of challenges, then they would have to explain why they're not following the toolkit. Does that make sense? Yeah. So there are different levers that are used nationally in terms of this. And so Abid mentioned that earlier, that sometimes the CCG requests that as part of the monitoring, or we use quality incentives like the Sequin to drive that need for. But I think it's about quality, because there's no point in indication being documented and then it's the wrong indication. And so that's why the national drive really has to be implemented within an organization, as Shazad and Abid have said, how they know best, how the team believe will work best within that organization.
Perfect. Thank you for your input. That's really interesting.
Good question. Thank you. And lastly, forgive me if I've pronounced this incorrectly, is Hayun?
Yes. Hi, my name is Hugh. I'm a provisional registered pharmacist and I'm working in hospital at the moment. So just thanks so much for Dr. Abid and Saz for your presentation. I just want to ask about the allergies. So throughout my practice, I've seen a lot of patients with penicillin allergy, but many times it was unable to actually whether it's true allergies, or we don't even confirm whether a patient actually have penicillin allergies or not. But most of the times, I think the clinicians are quite reluctant to prescribe any penicillin-based antibiotics. And I think it does increase the rate of resistance to other antibiotics like macrolides or cephalosporin. So how do you think we should combat this? Thanks so much.
Well, I'll take that one, Shazad. So that's a whole other discussion we could have over a much longer course. But very briefly, many trusts around the country are undertaking penicillin delabeling. And we're going to start doing the same shortly in Birmingham. So we will have a dedicated senior pharmacist whose responsibility it will be to identify those patients with a penicillin allergy label through a process of history, examination, and a flow chart, then determine if they can be delabeled on history alone, or if they need a penicillin challenge, usually oral amoxicillin. So I think many trusts around the country are looking at tackling this penicillin allergy problem. It's a work in progress.
Thank you so much, Dr. Abid.
Questions, and thank you,